Thank you all for joining today's session. I would now like to turn it over to our moderator for today, Erin Grace. Erin?
Thank you, Kara. Good morning or good afternoon, depending on what part of the country you're in. Thank you very much for joining our webinar today. This is a national web conference on the use of clinical decision support to improve medication management. My name is Erin Grace, and I'm a member of the Health IT portfolio at AHRQ. I'm the Chief of Health IT Translation, and we're located in the Center for Primary Care Prevention and Clinical Partnerships at the Agency for Healthcare Research and Quality, and I will be your moderator today. Our presenters today will be Madhukar Trivedi, Steve Simon, and Alexander Fix. And as you can see on this slide here, the disclosure of any conflicts of interest or financial interest. In order to allow participants to obtain continuing education credits, I am required to let you know that neither myself as the moderator nor Dr. Simon as a presenter have any conflicts of interest to disclose at this time. Dr. Trivedi would like to disclose that he has served as an advisor/consultant to or on the Speakers Bureau for several commercial entities and has received research support from Corcept Therapeutics, Inc. Dr. Fix would like to disclose that he is the co-inventor of the Care Assistant, the decision support software used in his study, but he has earned no income from nor holds a patent on this invention. And we'll talk a little bit more for those of you who are interested in receiving continuing education credits at the end of the presentation. We will talk about how you can do that. We will go through the presentations today with Dr. Trivedi first, followed by Dr. Simon, and then Dr. Fix. I will introduce each presenter right before their presentation, and we will hold questions until the end, and then we'll take questions for all presenters at the end. If you would like, you can use the Q&A box at the bottom of your screen. If you have a question and you want to be sure not to forget it, you can enter it in there, and we will take those questions at the end as we move through. So our first presenter today is Madhukar Trivedi. Dr. Trivedi is professor and chief of the Division of Mood Disorders in the Department of Psychiatry at the University of Texas Southwestern Medical Center in Dallas. And he holds the Betty Jo Hay Distinguished Chair in Mental Health. He is an established efficacy and effectiveness researcher in the treatment of depression and addictions with a focus on pharmacological, psychosocial, and other non-pharmacological treatments. Dr. Trivedi is a principal investigator in multiple clinical trials funded through the National Institutes of Mental Health and the Texas Department of Mental Health. So without further ado, I will turn this over to Dr. Trivedi.
Thank you very much. I'm going to try and go through my slides, and I assume if there are any questions, feel free to send them through the question and answer box, and there will be time for us to discuss at the end also. Well, the slides are not moving. Am I doing something? Okay, sorry. So let me go through. I think that I've already mentioned my disclosures, and although most of my current work that I'm going to present has been based on funding through NIH, AHRQ, and other national National Institute of Health institutes across the spectrum. My main focus is going to be on three things. So as you start thinking about what I'm talking about, you can imagine the three things are that there is a significant problem with diagnosis and monitoring of patients with major depression in the United States. The second component is that our studies and others have shown that the standardized use of measurements through the diagnosis and treatment of depression improves both recognition and treatment of patients. And the third most important thing is that mechanically and procedurally, it has been very hard for routine clinical practice settings to use measurements, and therefore we and others have been attempting to use IT in the service of ensuring that physicians and clinicians use measurements in the treatment of patients with depression. So those are the three areas, the first two being the rationale for why, and the third being how best to try to implement measurement-based care in routine practice. So this is now a little older snapshot at what happens in the United States for patients with major depression, and you can see from this chart that only about half the people with depression in any given 12-month period get diagnosed with the disease and achieve treatment. And those who get treatment, actually, 41.9%, only 41.9% of that half the population get minimally adequate treatment. And this, according to Ron Kessler's data, basically means they met minimal Otitis criteria, that is, patient was seen 3 times in 3 months. So clearly you can imagine that the problem is widespread in terms of underdiagnosis and undertreatment of patients with depression. We also have the other countervailing issues, and that is, even with the current treatments, even with the best of treatments available, any given treatment leads to remission in only about 1 out of 3 patients treated. So only 30% of patients actually achieve remission even with the first treatment. And I'll show you some of that data from the STAR-D trial in a minute. We also have a real paucity of novel treatments coming up. So actually, in the United States, of all the antidepressant treatments that are approved by the FDA, all of them work through one or the other monoaminergic neurotransmitter systems, serotonin, norepinephrine, dopamine, or a combination of thereof. And there have been no tremendously novel treatments that are FDA approved for the treatment of major depression. And then given these treatments, we have 35 antidepressant medications, at least 4 to 6 psychotherapies, exercise, and a number of other non-pharmacological treatments, including devices like transmagnetic stimulation. The practice patterns in the United States are very variable. The duration of treatment, as in do you treat patients for 3 weeks, 4 weeks, 6 weeks, 8 weeks before you decide this is not the right treatment? When do you switch to a second treatment? When do you augment the first treatment without stopping the first treatment? Are all kinds of questions that we are still trying to grapple with, and therefore some standardized measurements can actually assist you with at least having a good idea of what's really happening to the patient and then make judicious decisions. And then the overall problem is there are no standardized methods of assessing outcomes that are currently used in real-world practice. Obviously, there are things that are beginning to be more widely known, like PHQ-9, but they don't get used as often as we'd like. In the meantime, the APA guidelines came out in 2010, and they updated the guidelines, and the main real sort of novel things about the guidelines are that the guidelines recommend switching or augmentation after an inadequate response to an optimized initial antidepressant trial. There again, how do you define this inadequate response requires that you implement measurements. And if you do a poll of practicing clinicians, 70, 80, 90% of clinicians don't use routine measurements of symptoms and function and side effects in order to drive their treatment. So that's the first thing. The guidelines also say you should use measurement-based care to detect unresolved symptoms. And it also added recommendations for new treatments like atypical antipsychotics, transmagnetic stimulation, and exercise. So this is from the APA guidelines that came out in 2010. The guidelines really very well define the process that we should engage in if you start somebody on a medication or psychotherapy. And I'm not making any kind of recommendations on whether it should be medication or psychotherapy. That's a different discussion. The real issue is once you decide what is the treatment, how best to implement it is the real issue that I'm focusing on. And there, it strongly recommends that at the end of 4 to 8 weeks on any given treatment, you should reassess the adequacy of that response, and then based on the response, you can add, if the patient has full response, obviously you continue. If the patient has partial response, there are recommendations to either add psychotherapy or medication or the reverse, or switch to another antidepressant. And then for those who don't have any response, switching or changing the antidepressant treatment is recommended very strongly. So these are, again, recommendations. How you operationalize these, in my view, is really primarily through using measurement-based care. The goals of treatment are very obvious, that you want to reduce symptoms, achieve full remission, return patients to full possible function, and improve the treatment of comorbid medical conditions. So all these are goals within the treatment of depression, and again, driven by measurements is what I think is the central key issue. So we need to incorporate new treatments. Even though there has not been a novel antidepressant, I think that we all know that if somebody doesn't respond to one SSRI, you go to another SSRI, they still will respond, or an SNRI, or moving from a psychotherapy to medication, or moving from medication to psychotherapy. So we have to think about how you incorporate that in a treatment algorithm, how do you identify adequate trial duration, and then use measurement-based care in order to try to implement the goals of treatment, which is achieving remission. This is from a study we did some time back in the Texas Medication Algorithm Project through public sector settings. And the study actually was very straightforward. We had developed a treatment algorithm, and that was published in a peer-reviewed journal. And then we went to clinical practices, sort of public sector mental health, mental retardation practices in Texas, and identified places which would have used a treatment algorithm and compared that with the places that were using the usual best care practice treated by psychiatrists in the practice. And you can see from the graph that those patients who were treated with the algorithm, they had a significantly better outcome compared to those who had treatment as usual. Remember, no new different treatments, no novel medications were used in the algorithm arm. They were all treatments that were approved by the FDA and used commonly in practice. And yet, the use of the algorithm, which was mainly a measurement-based care approach, produced a better outcome than treatment as usual. That led us to then do the next large trial called the STAR-D trial, and those of you who have followed it, it's a sequence to treatment algorithm study where we studied 4 different steps in a treatment algorithm to see what is the sort of, if the first treatment doesn't work, what is the second one, what is the third, what is the fourth, and used measurement-based care again, where we drove the treatment in real practice settings in primary care and specialty care. So actually 40% of patients came from routine primary care practices and 60% came from psychiatry practices. We used a symptom rating scale and a medication side effect rating scale to drive the decision making. And the goal was remission of symptoms. That is, we said patients should achieve a SQIDS SR score of less than or equal to 5. And for the clinical decision-making, clinicians got regular feedback from us, the investigators. And these are the results from that large trial. It was 4,000 patients. We started with the first step, where the remission rate was about 33%. Those who did not remit on the first step then switched over to the second step, either through an augmentation or a switch to a new treatment. Produced about 25 to 33% remission rate. So those who did not do well on the first treatment but chose to get augmentation had a slightly better outcome. But we have to remember that those who got the augmentation were people who had some improvement on the first treatment and the side effects were tolerable. Otherwise, they would not have agreed to get to augmentation. So while it appears that the combination produced a slightly better outcome, we should be careful and not overinterpret. The big finding from this study, though, is that after the first 2 treatment steps, remission rates on any kind of other combinations or switching of antidepressants at the stage 3 and stage 4 are very modest. So therefore, clearly identifying that we need to be aggressive in treatment in the first 2 treatment steps in order to make sure that we maximize the outcomes. So in our settings, we think that measurement-based care really is designed to help with the associated wide variation among practitioners. Practitioners differ in how outcomes of treatment are assessed. And we also know that global judgments, that whether a patient comes in and the physician says, how are you doing, and the patient says, I'm better or worse, those judgments are not as effective in judging what the patient's clinical status is when compared to rating scales or itemized symptom measurement that should drive measurement-based care. So we think that there should be assessment of symptoms, function, side effects, and suicidal ideations. As you know, a number of antidepressant medications have been given a black box warning for suicidal ideation and suicidality, so we should always measure suicidal ideation, even for the disease itself, but in addition related to the treatment. Using critical decision points so that you know what to expect at week 4, 6, 8, 10, 12, as you go along. Very similar to what people do in hypertension and diabetes. They don't start insulin and say, come back in 6 months. There is an ongoing assessment, and the dose of the treatment is changed based on what the patient is experiencing. We should really engage in consistent follow-up, and performance feedback for clinical decision-making is very essential, and somehow that is, again, the kinds of things that IT can help so that everybody can have feedback as they are treating their patients. So one approach that we have tried to use is to integrate core components of these measurement-based systems with a depression algorithm, and so we developed this decision support tool. But any decision support tool that combines these should be considered as a very good, viable option. So there is nothing magical about the system we have developed except to say that we ensured that these components are integrated. And the idea is to maximize treatment delivery, make measurements-based care strategies accessible and user-friendly. Because one of the issues is measurement-based care. In principle, no clinician says, I don't want to use measurements. But when it comes to practice, in terms of implementing it in their practice, very rarely does that happen. So there is a big disconnect, and this is designed to help us with that. I think that very similar to what happened 30 years back with hypertension. People knew they had hypertension, they were being treated, and very few people monitored their blood pressure on an ongoing basis. Now even the local pharmacy or a Walgreens has a blood pressure measurement approach, and you can measure and monitor your blood pressure. I think a similar approach in terms of depression treatment is essential if we are going to improve outcomes. So this is one example of an approach of electronic system that can help, and this is a little busy slide, so I'm going to walk you through, but bottom line is at upper top hand corner, patient checks in, and there is a whole sequence of events where a patient checks in and gets their measurement of symptoms, side effects, adherence, etc., that is then fed into the second panel, which is the prescriber visit flow, where the patient's electronic health record then contains the information that was filled in by the patient about their symptoms, side effect, adherence to the treatment. And the physician then makes the decision based on these ratings, educates the patient about it, engages the patient in shared decision-making so that you educate the patient that your symptoms have gone up, your side effects are high, let's try to go to a second treatment. Or your symptoms have gone up, have gone down, side effects are still a problem. Do you think we should address the side effects with some kind of treatment? And then a final decision is made by the clinician with a expectation for regular follow-up. This is an example of the electronic decision support tool that we have developed, where you can actually keep track of the patient's clinical status as you go along in the evaluation screen, that then guides you to potential options for treatment. And if you can look at the top left-hand corner, based on the patient's current status, it appears that one of the two options, either continuing the dose or increasing the dose, both may be possible, and we need to try to figure out how best to make the decision. And this is where, when people ask me if an electronic solution will then, so to speak, quote unquote, take away the need for a physician or a clinician, and I say strongly that that is not the case, because in virtually a number of cases, 2 or 3 potential treatment recommendations are valid, and then clinical decision-making and judgment on the part of the clinician is the key. And here is a good example where, based on the previous assessment, patients' treatment options could include continued dose because you decide you may want to wait for a little bit before you do anything with the patient, or you decide, based on previous history or previous experience, that in this patient, increasing the dose and getting patient rapidly to remission is a better option, and you decide that and document the rationale for that. So we did a proof of concept study in primary care using the electronic decision support, where we studied 55 patients, 4 separate physicians, 2 used the clinical decision support, and 2 were using usual care, and this was published in the Primary Care Companion in 2008. And we found that patients whose physicians used the computer decision support tool got better improvement, statistically improved over usual care. I think the difference is modest, but the key issue is, if you go to clinicians and say, use this computerized decision support, they think it is going to hinder their care rather than help them. This shows that, if anything, it improves their care, but clearly does not hinder care, and you then have a long, ongoing monitoring of this outcome. So we then went further, and this is the grant we got from AHRQ, where we put the electronic decision support inside an electronic health record, and this is really where we went with the electronic health record to integrate our measurement-based care system. And what we were asking was, how is the treatment optimally implemented, as in adhering to a set visit schedule and dose titration? Is there monitoring of symptom improvement and monitoring of adherence and side effects? So critical decision points were provided for next step clinical decision making. And this was based on a symptom rating scale. We use something called the quick inventory of depressive symptoms. We have found it to be very useful, but there are other options people can use. I think the key issue is to have a very regular visit frequency. And so if you are going to make active decisions about the patient's clinical condition, but you don't see the patient frequently enough in the first 3 months, then, as we know from utilization databases, about 60% of patients stop taking their antidepressant medication within the first 12 weeks, suggesting that we really have to focus on this. And one way to do that is to sort of maximize visit frequency. Obviously, there is nothing rigid about it, so if you want to see a patient in 2 weeks or 3 weeks, there is clearly clinical judgment needed, and you can always get by with 4 weeks if the patient is willing to have a phone contact with you. This is the symptom rating scale that we have, which has very good metrics on what is full response or remission, etc. Similarly, a very easy-to-use side effect rating scale called frequency and intensity and burden of side effect ratings called FIBSR is a self-report rating scale, again talking about the frequency, about the side effects that the patient is experiencing. You always have to assess patient adherence, because often patients are not getting better because they think there is some degree of side effects, they stop taking treatments, and they don't remind. If you don't ask, the patients often won't tell. So I am going to stop here, and hopefully I didn't take too much more time than I had.
Thank you very much, Dr. Trivedi. We've had several questions, just to clarify for folks today. Dr. Trivedi was presenting on medication management and the use of clinical decision support for medication management related to depression. But we do have two additional presenters. There was some confusion. Folks thought this was just a conference about depression, which it is not. So our next presenter is Dr. Stephen Simon, and he is the chief of the Section of General Internal Medicine in the VA Boston Healthcare System and associate professor of medicine at Brigham and Women's Hospital and Harvard Medical School. His research focuses on interventions to improve the quality and safety of healthcare, with special emphasis on the use of educational programs and healthcare information technology to improve the delivery and receipt of care for common primary care conditions. A practicing internist, Dr. Simon serves on the Massachusetts Medical Society's Committee on Medical Education, and he will be talking about the use of clinical decision support to improve laboratory monitoring related to medication management. So for those of you who have joined a little bit late, just a reminder, in the Q&A box at the bottom right hand of your screen, we will be taking questions at the end of all three presentations, and but if you have a question that you'd like to at least get recorded before you forget it, please feel free to put that question in the Q&A box, and we will address those after all three presentations. So Dr. Simon, please go ahead. We look forward to your presentation.
Erin, thank you very much, and let me also thank AHRQ for their support of this work. So the topic is, as Erin introduced, clinical decision support to improve laboratory monitoring and timely follow-up of laboratory testing. The term laboratory monitoring here really refers not to monitoring the laboratories, of course, but monitoring medication use with laboratory testing. And in healthcare, particularly in ambulatory care and especially in primary care, a great number of medications require laboratory testing to assess both the efficacy of treatment, but also the safety and toxicity and ensuring the prevention of end organ unintended involvement and damage. Recommended monitoring is unfortunately not done with the frequency that we would like to see it. And in previous work that we and others have done, the rate of appropriate monitoring oftentimes is no greater than 50%. That is, roughly half the time patients receive certain medications, they do not have monitoring, laboratory testing, in the recommended time frame based on a variety of guidelines. And the importance of this work is that the lack of monitoring is associated with adverse drug events. And adverse drug events can be serious, fatal, and lead to as many as 7,000 deaths per year in this country. So we, therefore, given the seriousness of the issue and the apparent gap in our treatment of use of monitoring for treatment, we consider the possibility of using Health IT as a way to enhance the way clinicians order and perform laboratory testing. And over the past decade, as Dr. Trivedi's presentation just let us have some insight into, and other research over the years has shown that there's been increasing use of Health IT, specifically clinical decision support, alerts and reminders, to improve the way clinicians go about their daily business in real time, to modify and support their decision-making for ordering medications, for ordering laboratory studies, radiology testing. So we undertook this study because of the possibility that Health IT could improve rates of appropriate laboratory monitoring. Our objective then was to determine the effect of computerized clinical decision support on clinicians' adherence to recommended laboratory monitoring recommendations, guidelines, in ambulatory care. The setting for our study was a group of unrelated community practices in the New York City area. They were actually loosely affiliated with the City of New York's Primary Care Improvement Project, but they were not financially related to each other as practices go. And all of these practices used the same electronic health record, and this electronic health record had clinical decision support capability. We conducted a cluster randomized controlled trial. We had two periods, a pre and a post, or a baseline period, which was 1 year, middle of 2010 to the middle of 2011. And Our intervention period, our post, was June of 2011 until December 2011. The intervention was based on trying to improve the adherence of laboratory testing for the use of 32 target medications and classes, each requiring anywhere from 1 to 6 laboratory tests based on guidelines that we identified through review with literature, through discussion with an expert panel, through a focus group of physicians. And these 32 medications would appear as the usual suspects to anyone who is related to practicing primary care, ambulatory medicine. They included medications such as diuretics, ACE inhibitors. They included seizure medications, also included warfarin, one of the most common and worrisome medications with requiring monitoring. The clinical decision support tool that we built to be implemented within this electronic health record had the ability to look back and determine if the indicated test or tests had been performed for a patient receiving each of these medications in the preceding 365 days. We began with the assumption, as other literature has as well, that if the patient had received and had the test performed within a year prior to receiving a certain medication, then that would satisfy the requirement for laboratory monitoring at baseline. And if this wasn't done, then the alert was presented to the clinician at the time of medication ordering, and the alert said simply that the medication requires laboratory testing, and there's no evidence in the medical record that testing's been done, so you should order it, and gave the clinician guidance as to how to order it. I should point out that the decision support system at the time did not actually provide a direct link to ordering the laboratory testing. It only told the clinician to do so and told the clinician where to go in the electronic record to place the order. The primary outcome of the study was then the proportion of medications with appropriate laboratory monitoring defined as the completion of all laboratory testing anywhere from the 1 year prior or the 2 weeks following the date of the prescription. So again, a set of laboratory tests fulfilling the guidelines recommended for that medication. Laboratory testing done in the year before or the 2 weeks after the prescription would have satisfied the requirement for laboratory monitoring. Our patient characteristics in the control and intervention practices, there were 6 intervention practices and 5 control practices. You can see the numbers of patients was large. There was roughly 10,000 patients in each arm. These practices and the patients were relatively closely matched on age. The control patients were slightly more likely to be female, or the intervention patient more likely to be male in this case. There were some slight differences in the practices based on number of encounters. Number of medications was relatively well balanced across the 2 intervention arms, control and intervention. So this slide really summarizes the main results. And what you can see, and we'll take a moment to walk through this slide, what you can see on the left is that in the baseline period, in the bottom row, the rates of adherence to the guidelines were 70% or 70.7% in the control group and 79.4% in the intervention group. And this was a baseline before intervention. So we knew we had a discrepancy or a difference between intervention and control, which is a common occurrence in cluster randomized trials that don't have dozens and dozens of practices. And then in the post period, or the intervention period on the right side of the slide, you can see that, interestingly, the control group decreased its rate of adherence to the recommended guidelines to 62.4%, while in the intervention group, the rate was 77.7%, so almost no change. So I'll leave that there for a moment to reflect, because we've been struggling with these results and trying to understand them, because they weren't what we expected. To twist it a different way, both control and intervention groups did worse on adherence to guidelines for laboratory monitoring following the implementation of the intervention. It was just that the intervention group did less worse than the control group. So at baseline, the practices were similar in some ways, different in others, and we need to consider that in interpreting and further analysis. As I said, during the baseline period, there was a discrepancy between the control and the intervention practices in their baseline adherence to guidelines for laboratory monitoring. After the intervention, the control practices had a significant decline in their rate of adherence to guidelines, down to 62.4%, while the intervention practices remained relatively steady at 77.7%. Another key result to point out here is that when we looked at medications requiring 3 or more laboratory tests, and this is across both intervention and usual care practices, at most, 17.7% of these medications had evidence of complete laboratory monitoring. So the slight editorial comment here is that we know we raised the bar pretty high in requiring all the laboratory tests to be completed to satisfy the outcome for this, the outcome measure for this study. It would have been easy, and we still actually have plans to look at performance of part of the recommended guidelines. But we felt that for the main outcome measure, our a priori intention was to look at whether or not all laboratory testing for a given medication was performed. And some of these medications, for example, amiodarone, a medication used to control heart arrhythmias, requires 6 different laboratory tests for routine monitoring. And the more laboratory tests that were required, the harder it was to fulfill the guideline recommended measure. And as I said in the slide, only 17.7% of patients with receiving medications requiring 3 or more laboratory tests had evidence of complete monitoring. So the results that I've shown here are not adjusted for comorbidities, for the baseline differences in the rates between intervention and control, or by the clustering by provider. We've completed some of those analyses recently, and the results do not change much at all. And the overall results remain the same, particularly this phenomenon of the rate decreasing, the rate of adherence to the guidelines decreasing more in the control group than in the intervention group, but the overall trend decreasing in both arms. The other limitation of this work is that when laboratory testing is done, we weren't physically watching, monitoring, or reviewing the medical record by hand, so we don't know if the laboratory testing was done specifically to monitor the medication or if it was done coincidentally as part of routine medical care. Although adherence to laboratory monitoring did decrease over time in both intervention and control practices, we did note that it was less pronounced for the intervention group, so there may have been some effectiveness preventing the decline, if you will, attributable to the intervention in this study. What we don't know is exactly how to account for this secular trend, this decrease in adherence to guidelines in both the intervention and control practices. So further investigation really needs to try to understand what happened across these practices throughout this area. Some speculation we have is, was there a change in reimbursement for testing? We've explored that informally, and there was none. We know there was no apparent change in the guidelines, laboratory testing guidelines, over the time period of the study for the medications that were included. So that doesn't account for the apparent worsening of adherence to these guidelines. So the conclusion, though, is that interventions of this sort may need to target a variety of areas, not just the clinicians to decision support, but also patients, to try to address the complex behavior of laboratory testing, laboratory monitoring of medications. We'll be happy to take any questions if they're clarifying, or we can take questions at the end.
Thank you, Dr. Simon. We're planning to take questions at the end, but I might use the moderator's prerogative here for just a couple of the questions, because I think they are specific to the sort of clarifying questions to the slides that you just presented.
Sure.
So from Barbara Dunn, was curious as to what was the intervention time period?
So we studied it for 7 months.
Okay.
And it was in 2011.
Okay, thank you. And Laura Wood has asked, was the data analyzed at the ordering physician level?
So the unit of analysis was the medication, the prescription, and we did account, though, for clustering. I didn't show the data, but we've done the subsequent analysis accounting for clustering at the ordering physician level. But the unit of analysis was the medication, the prescription itself.
Okay, thank you. And then the final clarifying question, I think, is this system linked in any way, this is from Andrea Kelly, to adverse drug reporting systems in a way that could enable someone to trace the problem drug back to see if it received proper testing?
It's a great question. I don't believe it is, but I'll certainly inquire. And I don't know of any systems that do that yet. Even in the VA, there's no such sort of a closed-loop system. But I like the idea a lot.
Okay, and actually, there was one final clarifying question, and which is, was this study published?
Not yet.
Not yet. Okay, great. Thank you very much. I believe we now have...
Alex.
Hi, Alex. How are you?
Great. Sorry.
No problem. We were actually just getting to your presentation. Thank you, Dr. Simon. We just finished, so we've returned the ability to forward the slides over to you. You have that control now, and you do that by clicking the right arrow at the top of the screen that shows the slide numbers. And
perfect. Here it is.
Okay. If I can just introduce you briefly. Dr. Fix is an urban primary care pediatrician at the Children's Hospital of Philadelphia and an assistant professor of pediatrics at the University of Pennsylvania. He's also the associate medical director for the Pediatric Research Consortium, CHOP's practice-based research network, and the associate director of the American Academy of Pediatrics Pediatric Research in Office Settings, or PROS, which is a national research network. His research focuses on using health information technology to improve healthcare outcomes for children using strategies such as clinical decision support, telephony, and social media. He is also interested in how technology can be used to improve family participation in clinical decision-making, foster shared decision-making between clinicians and families, and improve health outcomes. Dr. Fix received his medical degree from Harvard University and received a Master's of Science in Clinical Epidemiology degree from the University of Pennsylvania. He has also received additional training in clinical informatics. And again, please, as Dr. Fix is doing his presentation, if you have questions that you don't want to forget, please jot them in the Q&A, and then we will address all questions from all presenters, except for those couple of clarifying questions we just took for Dr. Simon, when Dr. Fix's presentation is completed. Thank you very much.
Thanks, everyone. It's my pleasure to be part of the call. And my talk today is called Improving Adherence to Otitis Media Guidelines with Clinical Decision Support and Clinician Feedback. By way of background on clinical decision support, which is a topic that will be very familiar to many in the audience, physicians commonly fail to adhere to practice guidelines, and clinical decision support systems provide intelligently filtered, appropriately timed, and actionable information to clinicians at the point of care to really try to overcome these barriers to guideline adherence. Feedback is another commonly used strategy. So clinician performance feedback has been extensively studied as a means of delivering information on performance to clinicians. However, no previous studies before the one we did and I'll discuss today really examined the combined effects of performance feedback in addition to clinical decision support individualized to a patient's history and presentation. So the question is, is feedback equal to clinician decision support? Is it a stronger tool? And do the two together yield a result that's better than either one alone? And we'll explore a bunch of data concerning that question this afternoon. So we examined this question in the context of otitis media. And we chose otitis media because it's one of the most common disorders in childhood. Up to 60% of all children have experienced at least one episode of otitis media by the time they're 1 year old, and it's the third most common reason for a pediatric office visit, and the principal diagnosis in up to 12% of all office visits in pediatrics. And the American Academy of Pediatrics and the Centers for Disease Control and Prevention, as well as others, have developed guidelines for otitis media. However, as in so many conditions, studies really show that adherence to guidelines is lower than would be ideally expected. So the objectives of the project that we did were first to assess the effect of EHR-based clinical decision support with and without physician performance feedback on adherence to guidelines for acute otitis media. And second, to describe the adoption of otitis media clinical decision support and the effect of performance feedback on adoption. So the first question really concerns outcomes themselves. The second one really looks at, well, how much better could we do if people really used more often the decision support systems that were made available to them? So our study design was a practice-based study conducted in the Pediatric Research Consortium at the Children's Hospital of Philadelphia in 24 practices, and practices were cluster randomized using a factorial design. So what did that mean? There were a total of 24 practices. 8 of those practices got clinical decision support and feedback. 8 practices got clinical decision support alone. 4 practices only received feedback, and then another 4 received usual care alone. These were staggered over time. So the first phase of the study was a baseline period for 12 months where no practices received any intervention. Then, in phase 2, an 11-month period, 16 practices received the clinical decision support and 8 did not, but feedback hadn't yet begun. Then in phase 3, with an additional 10 months, half of the practices in each group, so 8 of the clinical decision support practices and 4 of the practices without clinical decision support, started to receive performance feedback. And we monitored outcomes throughout these periods. How did we measure outcomes? We used a set of otitis media quality metrics that were based on the nationally published guidelines. So for all otitis media, there's an emphasis on pain being assessed, and especially relevant to this conference on medication management, many looked at pain being treated. We also looked at acute otitis media, and there we looked at diagnostic evaluation, but also the use of amoxicillin appropriately as the first-line therapy, that appropriate antibiotics were prescribed if patients were penicillin allergic, that high-dose amoxicillin, that advised treatment recommendation dosing, was followed, and that for kids who didn't really need an antibiotic, who might have benefited from waiting as opposed to the immediate initiation of treatment, was something called watchful waiting used, where treatment isn't begun right away. Then for otitis media with effusion, which some people know affectionately as ear fluid, we looked for an adequate diagnostic evaluation, the avoidance of decongestants or antihistamines, as well as watchful waiting again, that people weren't treating ear fluid, which often resolves on its own, with antibiotics. So our clinical decision support system that we tested in this study was developed by the research team for the randomized controlled trial. It was delivered through a web service where the decision support itself lives outside the electronic health record, but the images that are created by the decision support and the information that is gathered is projected back into the electronic health record, so it appears seamlessly. It was designed to show up just for those with current ear complaints or a recent history of otitis media, so that in visits where that wasn't really relevant, it wasn't a distraction. And practices were trained to use the system, as well as trained regarding the otitis media guidelines in a 1-hour in-person session that was led by a physician member of our research team. So what did the decision support look like? This slide provides a visual display of otitis media events during the past 24 months. And this component of the decision support appeared for any visit with an ear-related problem and provided an aggregated history of previous otitis media encounters in the child's antibiotic history. A couple of things are noteworthy about this. one of the things that's received a fair bit of attention is that often in creating electronic health records or electronic technology, there's too much of an emphasis on recreating the patient chart in electronic form. And what we try to do with this history display is to comb through the chart in a problem-focused way and really distill the key elements that would be most relevant to clinicians in managing otitis media. So we looked at the history, those first lines which show episode history. We looked at when children had had acute otitis media or otitis media with effusion and showed those periods in a timeline. If there was laterality, in other words, if it was the right ear or the left ear, that also appeared in the decision support. If there were office visits, a history of those office visits was shown, and each dot provided a link where a click on that link would take the clinician to the office visit that was relevant. Telephone calls related to the ear history. Audiograms, which are hearing tests that would have been done in order to further investigate hearing problems in the context of the history, as well as referrals to specialists like ENT or surgery. Finally, the antibiotic history is shown, so it's very clear to people. And this antibiotic history, just because the sensitivities aren't just related to antibiotics for otitis, but any antibiotic use are shown. So all antibiotic use is shown along with the course for when it was used. And so you can see there's sulfamethoxazole trimethoprim, amoxicillin, clavulanate, amoxicillin, cephalexin or Keflex, cefuroxime, clindamycin, etc. And one other thing that appeared were high risk, factors that put children at high risk of complications from otitis media. So at the top of the screen, you can see developmental delays and weight loss, which were a couple of issues that put this child at potentially higher risk. Sorry, let's go back. The second component of the decision support was a tool to enter the history. In order to fire the decision support logic, it was important to have a few key elements captured as discrete data as opposed to just entered in with free text or from pick lists in the usual workflow. And so here you can see on the upper right that there is the physical exam, and clinicians would go through and check features that were present or not. It was relatively quick. The history of the present illness, key elements were captured, for example, the presence of recent history and whether the ear exam was normal, whether there was ear pain or drainage, and whether on further review of the history there was an ear complaint. And then the physical exam, is shown both on the top and bottom. The other thing that we made possible, both to be able to discuss with parents what some of these features would look like, and also as a reminder to clinicians, some of the folks in our setting are trainees, what a bulging ear might look like. We made images available, which was a nice feature that many people really found helpful. And then finally, once that information was entered, a link was clicked, and the tool provided an assessment and plan. So it gives a diagnosis, provides it facilitates prescribing of analgesia, in this case ibuprofen, at a dose that's calculated based on the weight of the child in this case. Documentation is provided, so the tool would actually write the clinician note based on the information that was entered in the history, and that could then be edited by the treating clinician. The specific antibiotic that was recommended based on the history and where things were in the guidelines was noted, and if there were multiple antibiotics, those were also noted. And the documentation, so there was two different kinds of documentation that was provided, one in the patient instructions and the other in the progress note. When someone clicked on that button that says process orders or diagnoses, an order set would come up with all of this pre-checked, and that could just be signed, and the care could be delivered to the patient in a facilitated way. In terms of the clinician feedback, we also developed feedback reports as part of this AHRQ-funded project. And so up on the upper left, you can see this is quality measure number 1. Reports were provided for all quality measures that were applicable at a given period of time. The clinician's performance was compared to top performers based on the idea that peer comparison feedback is more effective than simply providing feedback based on the clinician alone. And if we look at the bottom of the report, there is a timeline showing the most recent feedback period compared to prior periods, so that trends in performance could be watched. And also the individual clinician is able to compare him or herself to his practice and to the broader network of practices to know how they're doing. Again, with the notion that when there's a comparison or a benchmark, people are more likely to take notice and change. So our primary outcomes in this study, I showed those metrics previously, were adherence to the otitis media guidelines. That was for our primary aim. And then for our second aim, the primary outcome was adoption of clinical decision support use at eligible visits. The exposures for aim 1 included feedback and clinical decision support, and then in aim 2 we really asked about the effect of feedback. I'll go through these again as I present the results. And as covariates, we included visit, clinician, and patient level characteristics that were of relevance. Our study sample in the overall trial included data from nearly 140,000 otitis media visits between December 2007 and September 2010. Almost 56,000 children were involved at 24 practices and were treated by 182 clinicians. For our final data set, we excluded visits with residents, visits where the otitis media was resolved, and visits with otitis externa, which is a different condition. For our adoption analysis, specifically looking at use of the decision support system itself, we just included practices where the decision support was available. So that was 16 of the practices, and that included a total of approximately 41,000 visits. So what did we find? At baseline, comprehensive care where all the recommended guidelines, including those for antibiotic use, were adhered to was low, only 15% for acute otitis media and 5% for otitis media with effusion. Adherence to these guidelines increased during the intervention period. There was a larger increase for practices with clinical decision support versus non-clinical decision support practices. The magnitude of improvement was similar to what's been seen in meta-analyses of clinical decision support. So rates of comprehensive care for acute otitis media improved 4%. Rates of comprehensive care, again, meaning that all the relevant metrics were met for otitis media with effusion, improved 3%. Pain treatment improved 6%. Adequate otitis media with effusion diagnostic evaluation improved 5%, and amoxicillin as first line, a specific medication metric, improved 4%. All of those results were statistically significant. So overall, then, improvements in quality, as I mentioned, were similar to those observed. Additional point. Improvements in quality observed with feedback were similar to those observed with clinical decision support. So that question about whether feedback or clinical decision support would be better, we actually found a similar magnitude of improvement. And then our second question about whether there would be joint effects where you'd get more benefit from combining clinical decision support and feedback than either one alone. Based on our actual trial, we didn't find any additive effect. So doing both clinical decision support and feedback wasn't much better than doing clinical decision support or feedback alone in the trial. So then we went on to look at the adoption of the decision support system. So here the question was, if you were a clinician at a visit taking care of a patient for whom the decision support was relevant, how often did you use it? And we looked at that at the physician level and the practice level. So in both cases, rates of use were low, but similar to what I've seen in other studies. So clinicians used this clinical decision support at a mean of about 21% of eligible visits. But there was a wide range. The leading clinician used it at 85% of visits, whereas some used it at none at all. And then practices were similarly variable. Clinical decision support was used at a mean of 16.8% of eligible visits when we looked across practices, but the median was 15.1%, and the range there was from 0 to 50%. So also huge differences across practices and across clinicians in the use of the decision support system. So then we asked, what could we do to improve rates of use? Or specifically the question of could feedback improve clinical decision support. So the figure here includes two periods. The first period is a period of time when just the clinical decision support was available. And just because we had a relatively limited number of practices, randomization did not make the two groups equal, and the clinical decision support only practices started with much higher rates of decision support use. But then in that second period, to the right of the vertical line, you see when the feedback was available to the feedback practices. And if you look at the blue line, those were practices without the feedback. Their use of the clinical decision support continued a steady decline, whereas the practices that had feedback added began to use the clinical decision support more and more. So comparing that first period to the second period, the no feedback practices had a nearly 7% mean decrease in clinical decision support use, whereas the feedback practices had an increase in clinical decision support. So overall, there was a 9 percentage point relative improvement in clinical decision support with feedback compared to none. So to look at this in the broader perspective, what that means is that feedback actually proved to be a useful tool to increase the use of clinical decision support among those who had access to the tool. So now we're just looking at practices that had the clinical decision support available to them, and we're asking the question, if the clinical decision support was used by these clinicians compared to not used, how much of a difference in quality was observed? And here, the real importance of adoption of the clinical decision support is underscored, because whereas the differences in the trial were relatively modest, here we found much larger differences. So for all otitis media, when the clinical decision support was actually used, there was a 48% relative increase in medical treatment of pain. For acute otitis media, there was a 5% increase in the use of amoxicillin among those using the clinical decision support versus not, a 5% use in appropriate antibiotics for penicillin allergic patients, a 17% increase in high-dose amoxicillin, a 12% increase in adequate diagnostic evaluation for otitis media with effusion, and then an increase of 8 and 9 percentage points for acute otitis media and otitis media with effusion in terms of comprehensive care. That's the number of visits with perfect care. And all of those improvements were statistically significant. So among people who had access to the clinical decision support tool, use of the tool led to substantial improvements in the quality of otitis media care and in the medication management of this condition. So some limitations. The study was conducted at a single healthcare network in one region of the country, although the practices were clearly very varied. And the limited time frame of the study prevented a full understanding of how long feedback programs can influence provider behavior change, what happens when feedback is removed, or how long feedback must persist to achieve optimal effects. In conclusion, then, both CDS, clinical decision support, and performance feedback were effective strategies for improving adherence to otitis media guidelines, including antibiotic prescribing. Combining the two interventions was no better than either delivered alone in the large trial. We found low rates of clinical decision support adoption, which are common in various settings, and call for strategies that increase or foster clinical decision support use. And among those who had access to this clinical decision support, we found that feedback increased the use of the clinical decision support, and that clinical decision support users in that group delivered substantially better evidence-based care for otitis media. I want to acknowledge the network of primary care physicians and the Pediatric Consortium for their support. This project was supported by the Agency for Healthcare Research and Quality through an R18 grant and by the Eunice Kennedy Shriver National Institute of Child Health and Human Development through a K-23 award. And there are many people who contributed to the study. Some of them are named here. Dean Caraviti was notably omitted from this list. My contact information is shown, and I certainly welcome email exchanges related to the project following this call. Thanks very much, and I'd like to turn the program back over to the moderator to begin the question and answer.
Thank you so much, Dr. Fix. Excellent presentation. We actually had a comment in the Q&A to that effect, so I thank you very much for that. There are a couple of questions that I think are clarifying questions related to your presentation, so I thought maybe we should take those first, and then we'll move on to the other questions, which I think can probably be answered by several of you. Let me see. Okay. So the first one, I think well, maybe there's just one that's very specific to you, from Andrea Kelly, which is, when recording a patient's drug history in the system, what information was included? Brand name, NDC number, etc.
So thanks very much for that question. So on the back end, those codes were available. The data, so for example, NDC codes were available and other medication indexing codes in the EHR database underlying the system. What was used to fuel the decision support was much more of the clinical information, and so the information on the specific dose, which was partially entered as discrete data or was parsed based on free text in a SIG, and the duration of therapy and the particular agent were identified. So yes, we did to specifically answer that question, yes, we did use NDC codes, though we also, in order to get the specific details of how it was prescribed, used discrete data entered into the EHR or in combination with free text mining.
Great, thank you. Going to some more general questions, some of which were asked earlier in the presentation. One question from Tatiana Shamlian is, and I think any of our presenters can answer this question, what are the quality criteria for clinical decision support systems? Do you validate such systems before, during, and after implementation? I mean, I think you have all, Dr. Trivedi, Simon, and Fix, you've all come at clinical decision support from different angles, and so from your perspectives, did you have quality criteria? Well, and you also developed your systems as well, but as you think about clinical decision support writ large, do you have quality criteria or something for our listeners in terms of how you validate those systems?
Erin, this is Stephen Simon. I'll add a few thoughts. So there really aren't, to my knowledge, a widely established set of criteria on which to judge decisions for clinical decision support. I think for many of us, I think whether it works or not to produce the outcome without unintended consequences is the gold standard. But in developing it, you don't really know. You base the development on a variety of principles. I think back to the 10 Commandments of Decision Support article that David Bates and colleagues, I believe, wrote more than a decade ago, or nearly a decade ago. And you try to make things simple to view and don't overload with information. And there's debate in the field as to whether or not these alerts should be interruptive or not. So I'd be happy to hear what my fellow panelists say, but to my knowledge, there really aren't any established criteria other than testing whether it works and whether it works without causing unintended consequences.
So I agree. I mean, I think the two key things for our sort of approach has been twofold, and I think it encompasses both what you said. One is, does it improve clinical outcomes? That is very easy to validate and record. And the other, in the process, which is what you mean by unintended consequences, is it user-friendly that Even if it produces very good outcomes, but nobody is going to use it, then it is useless. So you have to make it user-friendly. Are the two issues. So we study physician acceptance, patient acceptance. We have data on that shows that our support systems and the interface that we have developed are all very acceptable to, in fact, the people, clinicians especially like it. But the proof is ultimately in whether you improve clinical outcomes. And, we have shown that, you showed that, so others have shown that. So if a decision support produces clinical outcomes that are superior to usual care, and it is user-friendly, then I think you've hit gold.
And it's Alex Fix here. I can just comment a little bit on some of the upstream things that we do. So in the development process, we generally do a series of iterative manual chart reviews to make sure that the decision support is producing, logic and outcomes that match what it should in different clinical cases. In the example of otitis media, that got very complicated because of the many, many different ways that something as simple as an ear exam might be recorded. And then the other thing we've learned the hard way is that the initial rollout seems to be incredibly important, and so you don't want to expose people to a flawed system because then sometimes they never come back. And so we generally pilot test with a small group of very invested users and then go a little bit bigger, perhaps to a single site or a single area before rolling out more broadly, and try to do as much as we can to gather feedback. And I agree with the comments of the other presenters as well.
Great, thank you. Early on in the presentation, we had a question by Barbara Dunn, and so this may be specific to your presentation, Dr. Trivedi. And her question is, in addition to the patient-reported tools of symptom reduction and side effects, are there other types of tools you would recommend to round out the MBC, which I think was your an acronym for measurement-based care? So would you recommend other types of tools to round out measurement-based care, such as functional assessment or general health assessment, for example, the SF-12?
So yes, we have actually a whole menu that clinicians can choose that include functional measures and work productivity measures. We are more interested in work productivity, so we use a work productivity assessment scale. And we also have measures of suicidality, etc. I think that the key issue is, as was raised earlier, we have sort of personally made the judgment that a minimal number of measurements that are essential for decision making are the core decision tools, and so that's where symptoms, side effects, and adherence come in. Then there is an additional number of the assessment tools that are available at the luxury of the clinician, but are not put in as essential because we want to walk the fine line so that it's not so burdensome that it gives you a much better tool, but in the process nobody wants to use it. So that's why we have erred on trying to include the three that I mentioned in our MBC software as the main issues, so some symptoms, side effects, and adherence, and then have the additional measures that include function, work productivity, suicidality.
Great, thank you. We had another question, and I think this might be for Dr. Simon from Zahid Butt, who is wondering, did the significant drop in the number of patients in both follow-up groups influence the results?
Well, so thanks for the question. It continues to, frankly, to perplex us. So I guess I would say it influences our interpretation. Those are the results. And as I said, we continue to struggle to understand, and within the limits of our data, we can't really understand why there was a secular trend both across the whole population, the intervention and the control practices, of a decrease in adherence. So I think it leaves a lot of question about the interpretation of the results. But as I said, I think it's encouraging that the intervention group didn't fall as far as the usual care group, suggesting some effect of stepping back in the context of the whole picture, it leaves a lot of question marks. So I hope that answers your question.
Thank you. A question from Tara Trujillo, and I apologize for probably slaughtering some of your names. And this is actually, for me anyway, I had a similar question as Dr. Fix was speaking, but I think any of you can answer it because you've all sort of created a clinical decision support for a specific either disease in the case of otitis media or depression or a specific type of care, so doing lab reviews of medication to help manage medication dosage and so on. Do providers have to purchase CDS separately, and how do they ensure that those CDS platforms interact with a client's EHR? And I would add on a third question, which is, at least from your presentations, it seems that clinical decision support is sort of evolving on a disease-specific or a type of management-specific basis. And so is that sort of a realistic way to design clinical decision support, and then would providers have to potentially implement multiple clinical decision support systems? So that was kind of maybe do providers have to purchase separately, and how do you know that it'll interact with your EHR, the platform will interact with your EHR is the easier question. Maybe you want to start with that.
So at least we have decided that we basically integrate the decision support into any EHR. So we've been working with 4 or 5 different systems, healthcare systems, where Epic and Allscript and InfoScript are examples of electronic health records that we have basically integrated our decision support within, because at least our experience is that a standalone decision support that doesn't talk to and imperceptibly moves across EHR is unlikely to be used. And
so, Dr. Trivedi, or any of the panelists, I mean, I think the first part of the question was, do providers have to purchase CDS separately? So has it been your experience that for the most part, your sort of base EHR will probably not include clinical decision support, or may include just very basic clinical decision support, and other more specific CDS would need to be purchased separately?
So, this is Stephen Simon. I'm sorry, I was going to say that it's been my experience that increasingly, especially based on the last few years of efforts to be adherent with meaningful use guidelines, most electronic health records do, in fact, include significant amounts of decision support. And, in fact, it was one of our challenges early on in the design of the study that we had to modify our approach, because we had the EHR that we had intended to work with had gone to version advancement and had effectively incorporated our planned intervention before we could even launch the randomized trial. So I think these days most clinicians who use certified EHRs should find that they have considerable amounts of decision support. So the real question is whether that decision support leads to improved outcomes, and that's the struggle to try to prove.
And I think the decision support leading to improved outcomes is also the idea, I think, is you want to be that healthcare system or the EHR has to collaboratively work with people who are assisting with the decision support, because over time it has to be improvised, because new treatments come in, new findings come in that would require you to modify it. So I don't think it is really a off-the-shelf kind of an approach. I think just the way Dr. Simon is describing, increasingly EHRs will incorporate a larger and larger component of these decision supports within their system.
Thank you very much.
I think the bigger challenge is that even when these decision support tools are available in electronic health record systems, clinicians are not utilizing them. So I think the real issue is that once we show that a particular approach at decision support improves clinical outcome, then clinicians will use more of it. Right now, there is variable evidence that the use of a particular approach to decision support is improving outcomes. So until that is out there where several approaches are studied and whatever makes best sense is then incorporated into an EHR, that's really the key. It sounded like a profound statement.
Oh, sorry. I was actually moving on to the next question, but I was on mute, so nobody could hear me. Similar to the last question, are all the CDS tools that the panelists talked about today, so the three systems that you mentioned, compatible with different EHR platforms? So, Dr. Trivedi, you've kind of answered that you're working with several different EHRs to make your clinical decision support work with them. So maybe from Dr. Simon and Dr. Fix, are your clinical decision support tools compatible with different EHR platforms such as NextGen, Success, Epic, GE Centricity, eClinicalWorks, et cetera?
So I'll just say, in our work, it's Steve and Simon, our project was built within Practice All using eClinicalWorks, and we are hopeful that eClinicalWorks will consider adopting this as their standard release. They have not yet. It would not be compatible without significant programming into other systems. But my guess is other systems, actually I know variety of systems do have similar kinds of alerts. I just don't know if you stack them up one-to-one, if they cover the same medications for the same laboratory tests and how their appearance is different. But this was done in eClinicalWorks.
Right, and Alex Fix here. So our system was developed in Epic and really was, at the point we tested it, just compatible with Epic. We have plans to broaden the framework to make it compatible with other systems, but haven't gotten there yet. But I very much agree with sort of the broader statements from the other panelists that as things are proven to be effective and make a difference, then the next stage often can be trying to either A, incorporate them into different EHR systems as part of the basic package so they're available to everyone, or which is a little bit of a bigger, broader goal, create services that supply decision support across platforms, and then people with different EHRs can potentially pick and choose, and the best can be selected. But I don't think that type of approach has really taken off in many settings, at least.
Thank you. We have about 5 more minutes and probably another 10 or so questions, so I'll try to move us to get through as many of them as we can. From Barbara Dunn was a question, are there any differences in approaching decision support for mental health disorders versus physical health disorders? She said, I'm thinking specifically of views, integration of relevant health data, scope of team members, and feedback to consumers.
So I can say in our work and some of the more recent things we're doing, we're really trying to get information from the patient and family into the system. For example, in some work we're doing with asthma and additional work we'll be doing in attention deficit hyperactivity disorder, that the notion is to get information from patients and families from the health system, potentially from specialists who aren't in the same health system, or others in people's lives like home health care providers or teachers in the case of children, and integrate all of those perspectives into a more complete decision support picture. But that work is challenging and one step at a time. But I think ultimately the vision would be that all aspects of health are better integrated.
Thank you. So I think in Dr. Fix, I think in your presentation, and probably Drs. Trivedi and Simon would agree with you. You mentioned that we need to sort of increase adoption and use of clinical decision support. That was sort of one of the findings from your study. So Tara asked the question, what are effective strategies to increase clinical decision support use, if any of you have some background on that?
So I think all the things we talked about are essential. Like, it has to be worthwhile, so it improves outcomes. It has to be user-friendly. We have to take some effort, make some effort at training, or at least providing good enough education rationale for it. And the bigger piece that is already coming down quickly, and I think that's going to make the biggest difference, and that is reimbursement. So we are finding for depression, because now there is a requirement from meaningful use from CMS for screening for depression, we are finding that more and more healthcare systems are coming to us asking us to provide support so that they can put our decision support in their EHR so they can then screen everyone in order to meet the requirements of meaningful use.
Anybody want to add anything to that?
I mean, I think that our study sort of suggested also giving people feedback on how they're using the decision support compared to others, how others are using the decision support, and also giving people feedback on how well they're doing with a particular problem compared to others. For example, to take the depression example, if someone was treating depression in a much less evidence-based than another, and it was sort of pointed out in a feedback report, that might help to motivate, as part of a larger program, increased attention to a decision support system that made it easy to do the right thing for depression.
And even there, I think the tie-in to reimbursement is coming related to it also, is that not only is it clinically necessary that I do, so to speak, as well or as better than you, but that my reimbursement is going to be tied to outcomes that are based on good practices and evidence-based guidelines. So if I get reports that are less than optimal, then I'm likely to use it more.
Right. Thank you. I think this one is a quick question, and then we might be able to take one, maybe two more. And I see some of our panelists are typing in answers to questions, which is great. Rebecca Birch asked, what is an RA? And I'm not sure. I think that might have been during Dr. Simon's presentation. Was that a research assistant?
I think I meant research assistant, yes, probably at the time. I don't recall exactly.
Okay.
That'll be the likely thing.
Okay. Go ahead.
But a medical assistant of any kind can perform that task.
We have a couple of staffing questions. So one person was thanking for the fascinating study, and I'm not sure, again, exactly which presentation, but we've had positive comments on all three presentations. But one question is, were there any differing roles among office staff and or pharmacists in terms of their post-prescribing contact with patients, remind them to get monitoring? And another similar question, and I think this must be for Dr. Simon, which he was answering already. Do the panelists utilize clinical pharmacists in their teams? So did you find...
Yeah, just to emphasize, we do, and in our practices, and I know a variety of places, but not in the study I described in this presentation, and I think it's typically more in the larger systems, not so much in the community practices that we did our intervention in.
Okay, thank you. And wow, we can maybe do one more question, which is this is sort of going back a few questions, but going to build on a question that was asked previously, and this will probably be our last question. Dr. Fix, could you expand a bit on the web-based clinical decision support, specifically how that worked within the EHR?
So Exactly how that work has evolved a little bit since our first iteration of it, but EPIC, which was the EHR we used, allows, through a system called Interconnect, the communication of information between the electronic health records and an external web service. And so, without getting overly technical, what happens is that the clinical data that's relevant to provide a clinical decision support rule is captured out of the electronic health record. If needed, as I showed in one of the slides, in some cases a little additional information was needed to supplement it. That's also gathered. That is all goes out of the EHR to a web service which has an independent logic engine, which then processes that data, and then through that same interconnect system, the web service returns the information to what appears to be like a little piece of the window. Those different screenshots I showed were windows within that sort of look seamlessly like they're part of the electronic health record, but they're coming from the outside, and they provide answers, and then they can also be used to trigger the order sets that are inherent to the EHR. So the web service essentially takes the relevant information out, organizes it, and presents it back so that it's actionable, but in a way that really takes advantage of the electronic format of the data, which sometimes is lost in native EHR implementations that so often just sort of recreate a paper version without doing as much as could be done in terms of information synthesis and organization.
Thank you. And we're now a couple minutes past the hour. I would like to thank Dr. Trivedi, Dr. Simon, and Dr. Fix. Obviously, with this generated a lot of discussion, and I thank you for your time in putting together your presentations and then spending some time with us to answer questions. We've had a couple questions about the slides, which will be made available within a couple of weeks. Someone also asked if this recording will be archived, and I think the answer is yes, and again, within a couple of weeks. And you'll be able to find that on the AHRQ Health IT website. And Stephanie or Kara, if I have misstated that, please correct me. Up on the screen now is information on how to gain CME or CNE credits if you would like to do that. And you also, when you sign off, will be receiving an evaluation screen will pop up. And so any feedback that you give us is always helpful as we work towards additional web conferences. So I'd like to thank everybody for your participation, and in particular our panelists. I'd like to thank you very, very much for your time before and during the conference, and we look forward to hearing from you again sometime.
Thanks very much. It's my pleasure.
Thank you. Terrific.
Kara, anything else housekeeping-wise?
No, ladies and gentlemen, thank you for your time and attention today. That does conclude today's presentation, and you may now disconnect.